welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello, good morning once again, and a very warm welcome to our CATHIP Health Hour session today, the 18th of June. We, as always, have a very stimulating discussion today. We are on Zoom, we are also on YouTube, streaming to YouTube, and also live on Facebook. So we welcome all our viewers and our audiences, wherever you are joining us today. Week in, week out, we bring you stimulating topics, discussions centered around lots of areas that are useful. And we always endeavor to bring experienced consultants or GPs or clinicians who can give us insight into these areas. So once again, today we have another interesting discussion on skin conditions in the Black skin. So that is a very exciting topic that we've got today, because it can be quite difficult or challenging to identify some conditions on a darker skin. Sometimes there could be other things that confound the diagnosis. My name is Dr. Diana Asante. I'm a GP. I'll be your host today. But more importantly, we have a very experienced GP who is also subspecialized in dermatology and skin conditions, and he will be presenting for us today. At the end of the presentation, we will have a Q&A session where we go through the questions that have been posted in the chat box. So please do feel free to post your questions as we go along. Do feel free to send them in so that we will come to them in the Q&A session. We really appreciate your time and all your energy in joining us every single Saturday for these sessions, and we hope that they are very useful for you. So it's my pleasure to welcome Dr. Kwasi Appiah to take the stage, take us through the session for today's topic about skin conditions in the Black skin. Over to you, Dr. Kwasi Appiah, and thank you so much for honoring our invitation.
Thank you, Dr. Asante. Thank you for invitation for CAHN. And it's really a pleasure to be back again. And it's always good when you're always invited back to do a session. So this is my third time speaking to your group, and I'm just pleased to be back again. So as Dr. Asante said, my name is Dr. Kwasi Appiah. I'm a GP with a special interest in dermatology, or we call it GP with extended role in dermatology. And I work in East and North Hertfordshire as a GP, and also in West Essex and Mid Essex as a GP with a special interest in dermatology. So my background is as a GP. I trained in East London, in Whitechapel, Barts under London. And so what's as time in medical school was quite exposed to ethnic skin in that part of the country when you're training, but recognized the shortfalls in our training as doctors when it comes to skin conditions. So I think this is a very interesting topic, and is very much in the forefront of medical training in current climates as well. And so I hope that we can discuss it and things that will be quite helpful to the audience that we have today. Hopefully I can share some experiences and something useful for you. So our objectives today is to look at some of the challenges that we face, or challenges faced by UK medical doctors when it comes to skin conditions. And then also we'll look at some of the skin conditions in adults, children, and pregnant women, and how it looks different or presents commonly in pigmented skin. The other thing I also like to consider as part of the talk today is some of our cultural practices that lead to some dermatological conditions, and also the health, the risk of health and misdiagnosis or morbidity as of underdiagnosis of skin conditions in black skin. And also I'll touch briefly on some of the treatments available, and also, you know, where doctors in the country can use in skin conditions. So let's see, right. Okay, so the challenges in black skin for UK medical practitioners is very well known. And even though the skin is the largest organ in the body, dermatology itself, which is the study of skin conditions, is only afforded very little time in training in medical school. So as far as I can remember in my own training in medical school, we only had about 2 weeks of dermatological training. And that's alone, let alone any specialized training in dermatology in skins of black skin. The skin type is challenging for Western trained doctors because most of Western trained doctors, and not even just Western trained doctors, doctors trained around the world, are unfamiliar with skin type 4, 5, and 6, which is black skin, Asian skin, Afro-Caribbean skin. And that's what the skin types usually describes how your UV light is absorbed in the skin. So type 1 will be the redhead, blue-eyed skins who always burn and always tan and never tan. And type 2 skins are white Caucasian skin who never burn but always tan. And then type 3 are those who easily tan, but a little bit lighter skin, but not mixed skin in that category. And then some light Asian skin, and also then you come to type 4, 5, and 6. Then you're thinking about Asian, South Asian, and then 5 is mixed skin, and then Afro-Caribbean skin, more type 6. So there is a whole spectrum of skin types. We call it a Fitzpatrick skin type, and that's particular pattern is determined on reactivity to sunlight. So in the UK demographic shows that about 8 to about 8.9% is non-white skin, and that was in 2001, and as until 2011 that's gone up to 14%. And the challenge that UK doctors face is that textbooks in dermatology, even not UK or even in Africa, and in fact, I was speaking to some of our colleagues who were trained in India, all use textbooks from England. So the British textbooks, you might mainly find Caucasian skin in demonstrating skin conditions or illustrating skin conditions as you're studying. So you get very little exposure in black and brown skin. And this was very evident when a training dermatologists, consultant dermatologists, and trainees were asked this question about their experience, and 78% or 78 respondents say 22% have had only formal teaching in skin of color. When we say skin of color, we usually talk about skin of brown, Asian, and black skin. So that's the broad category. And also sometimes you come in Latino skin is also put into the same category. So there is only 22% had any formal teaching. These are consultant dermatologists that you see as specialists in the hospital. And also only 4% had a sort of ethnic dermatology skin clinic as part of their training. So this is no surprising that when they get into the practice, they have very little exposure, and challenges are faced when they are making diagnosis. This is the demographics of the UK population, and it's estimated that by the year 2051, the non-white population in the UK is projected to increase to about 21%, and with a white population being about 79%. So potentially there's 21% of the population of skin type or skin of color type of Asian, brown, black, mixed, Afro-Caribbean will be the majority of the population will be seeing doctors who have very little experience or exposure in managing skin conditions of their skin type. And so this is quite worrying. But I would say there has been some good response to this, because just until last year, there was no part of skin of color or black, brown, Asian skin in part of the curriculum of training among UK dermatologists. So last year was the first time where a very well-known consultant in Croydon, Dr. Sharon Belmo, wrote a chapter of the training manual for dermatologists, which is entitled Skin of Color. And that was the first time such a chapter has been incorporated in the formal teaching in UK dermatologists, and that is 2021. So it is very, very in the forefront, and really acknowledged by everybody that this is being a challenge and is being addressed. Black skin presents certain challenges to doctors because the black skin itself is more compact and it allows less transmission of UV light. But this is to warn you that UV light is not absolute protection from radiations from black skin. So you can still get burned, even though you might not have a higher risk of skin cancer, but you still have to protect your skin from UV radiation, because being black does not necessarily mean you don't need some protection. Also, higher water loss means that there's a greater tendency of dryness of the black skin, but in actual sense, there is no much difference in the amount of cells that produce melanin per unit area among all races. What is determined by genetics is really the amount of cells that the production of the melanin itself. So you might have the same amount of cells that produce melanin, but the activity of production of melanin is determined by race and genetics. So that's the only thing difference. And also the top layer of black skin, which has more melanin stored there, whereas in white and Caucasian skin, the melanin is stored in the lower or the basal layer of the skin. This also has other problems. The other things that you find different is sweat glands. So through evolution, there has been an adaptation of the sweat glands, and it means that more African Americans seem to have much more active sweat glands, and obviously due to evolution in the tropics, and therefore that's been a protective thing because of the strong heat. The other challenge in dermatology is not about skin. Dermatology is also about hair, and dermatology is also about nails as well. Hair in Black people are much more helical, spiral shafted, and therefore that increases the risk of ingrowing hair, where the hair tends to coil itself back into the skin. There is also, just to realize, there's no difference between the deeper layer of the skin and the fat amongst all races. And also, because of sun-exposed skin of the Caucasian subjects showed, because they have reduced extensibility and they have less elastic protection, and therefore photoaging is much more common in Caucasian skin and less common in Black skin. So this different presentation makes it very difficult for clinicians and doctors to appreciate in Black skin, particularly redness. So in dermatology or in medicine, we'll call it erythema or redness. So if they say some skin is inflamed, all our textbooks tells you the size of inflammation, redness and heat and swelling. And you cannot really appreciate redness in Black skin because it doesn't show red. It might show a tinge of purplish rays. So it's not very difficult for doctors to make accurate diagnosis of inflammation on Black skin. The other thing that's really important to Black skin is the importance of hyperpigmentation, which is darkening of the area. Also, the opposite of hypopigmentation, which is lightening of the skin, is also an important clinical clue for certain conditions, and certain conditions like vitiligo or other inflammatory conditions can also present with areas of hypo or lightening of the skin. The other thing to also consider is a difference in pattern presentation of certain skin conditions. So whereas in a white skin, a certain condition will present with redness and scale, in a Black skin, it might not be redness, it might be more of what we call follicular or sandpaper appearance, and particularly in a condition like eczema. So eczema might not present with a redness and inflamed scales, as you can see in white skin. It might only have a pattern of sandpaper feeling in a Black skin. And also the secondary effects of rubbing, itching has much more greater impact on Black skin. So I'm going to show you some pictures. Dermatology is about pictures and pattern recognition. That's really the mainstay of dermatology. And these conditions are quite normal variants in Black skin. So this is a condition we call idiopathic because we don't know the cause. That's always when any doctor mentions idiopathic, because we don't know. Or Guttate Hypomelanosis, which is Guttate is like raindrop appearance. And this is pale pigmentation, particularly found on the limbs, the lower legs or upper limbs, or sometimes on the torso of Black people. And sometimes it might be misdiagnosed as things like pityriasis, which is a fungal condition, or even worry of vitiligo. But this is a normal variant, and really it is just a normal presentation, and sometimes might be related to sun exposure or not at all. So that's idiopathic Guttate hypomelanosis. Nobody knows what triggers them, but some people do get it and find them on their skin, and it's benign and no problem at all. The other thing is also what we call benign longitudinal melanechia or ethnic melanechia, which is dark longitudinal pigmentation of the nails. And this is really important because for a doctor or a UK trained doctor, we are told to look out for melanomas in the skin, and particularly in the melanomas in the nail. And if you have not been exposed to this and you don't put the presentation in the context of the race and the duration, you might look at this on a Black patient and you might worry about a nail cancer or melanoma in the nail. Having said that, there are certain things to look out for. Something which is not new, something which is very new, or something which is not long-standing and it's just come more rapidly. If you see some nail changes and your doctor is not aware, you might need to check it. Normally, with this benign one, it will be long-standing, and you ask the patient, they've always had it on throughout their life. And also, it will be on multiple nails. You have these longitudinal lines in multiple nails rather than a single nail. And that's really not a skin cancer. This is a DPN, or dermatosis papulosa nigra, which is, you see Morgan Freeman's face there. And it's this very brown, what we call lesions on the face, or any part of the body of black skin in particular. There is a normal variant that Caucasians have, which we call a seborrheic keratosis or age spot, or sometimes they call them warts. They are not warts because they are not infections. This is just a normal variant in the population and purely benign. They are much more of a cosmetic nuisance, and some private specialists will be happy to remove these things privately for you. Certainly you won't get any treatment for this on the NHS because it's purely cosmetic. The other time I did a presentation, I think we had a midwife who was really keen for us to do something of some of the changes that you see in pregnant women. This is a condition called melasma, which is brown patches that you usually get on the face. And it can be very common in pregnancy, and not only in pregnancy, or it can be in young women on the contraceptive pill, the combined contraceptive pill. So it can be related to the estrogen levels in the body. So it's very common, and sometimes it might be difficult to go away completely after the pregnancy. And there are some creams and treatment for this, including tablets, which are used to treat bleeding disorders, which can be used in treating this. And there are some creams which you can actually buy and get them over the counter. There are some creams called thiamidol. I'll show you some pictures of hyperpigmentation creams that you can buy over the counter, which can be helpful in treating conditions like melasma. You might be able to get GPs to prescribe certain type of creams for this, creams like azelaic acid, which GPs can use to treat acne, can respond well in treating melasma. But there are other creams which are not available on NHS, which are used to treat this, which I'll show you in a minute. There's something called Pigmentation. Other physiological changes in pregnancy is the stretch marks related to pregnancies always get darker. As I said, the pregnancy hormone is the same precursor for melanin formation, and therefore it makes part of the skin darker. Hence, everything gets darker when you're pregnant. So the lines, the stretch marks, the linea nigra or stratum gravidarum all gets darker with pregnancy. In a Caucasian skin, if instead of the dark patches on the stretch marks, they will look red, and that's the difference. But they can still also get these black marks or lines in the middle of the fundus of the pregnancy bump. So those are the things. The other things that you can get in pregnancy is you can get the nail breaking, what we call distal inequalities. This is also physiological changes that you can get. You can get the dark pigmentation that I said about the nails, which is the longitudinal ones. They also get darker, and these are all fine. They are all physiological changes in pregnancy. Hair problem. I mean, hair is quite important to women, and unfortunately during pregnancy there are certain hair conditions that becomes very much more common. This is a condition called Telogen Effluvium. When you brush your hair and you comb your hair, you see a lot of hair falling out, and that can also be as a result of pregnancy. The other opposite is excessive hair in the beard and also around the mouth and chin area, or hirsutism as excessive hair, and much more of the male hormone distribution in that can be a problem with pregnancy as well. So those are hair changes as well. Telogen effluvium is not only related to pregnancy, that can also be related to iron deficiency, vitamin D deficiency, folic acid deficiency, and things like that, and general tiredness, stress. That the skin gets the brunt of how we feel inside, and also sometimes when our diet is bad, you can get a lot of hair falling out as well. So it's not just pregnancy. And then there are certain specific conditions which are on in itself is not they are not physiological changes, but they're conditions related to pregnancy, which makes you helps you to try and recognize those signs in a skin of color and a black skin. So look out for jaundice, so the yellowness around the eye, so the white bit of the eye becomes yellow. That's the easiest sign to look for jaundice, because in a Caucasian skin, jaundice might be quite visible on the skin, but in a black skin, you really much should have to look at in the eye to see if they've got jaundice, which is because of pressures in the liver during pregnancy, and it can leave you with excessive itching symptoms. So this is things to recognize if you're getting excessive itchiness on the skin, as well as going yellow. And if you're pregnant, you need to seek medical help for that. There is another condition related to pregnancy known as Pyritic Urticarial Papules and Plaques, or PAP for short. PAP is a very incredibly itchy. Pyritic means it's very itchy. It is raised as wheels, and sometimes it is bubbly on the skin, or flat raised on the skin. That's what plaques are. And this can be related to pregnancy. Sometimes this happen much more in the later end of pregnancy, and unfortunately, there's quite a difficult to treat. Doctors or obstetricians may try some creams like steroids to reduce the itching, but ultimately, delivery of the baby might be their answer to kind of cure this condition. The other ones are blisters that you can get on during pregnancy, and it's a condition known as Pemphigoid Gestation, which is pemphigoid is a blistering skin condition where you get skin bubbles and very incredibly itchy as well, and it can be difficult to see, and sometimes you don't always get the blisters, but you can see all these brown patches on this first picture, which are quite incredibly itchy. And this is much more of, we call it pre-bullous, before the blisters come up area, and then you can get a full bullous or blistering part of it as well. Again, these are quite challenging to treat, and sometimes the patients, the pregnant woman, might need a bit of steroid. That's what we use to treat them in dermatology. Just generally certain things that can get worsened during pregnancy, like acne, eczema, psoriasis. If you have eczema around the mouth, they can get worsened during pregnancy. Skin tags, as I said, can get a lot more during pregnancy. People with lupus can get more during pregnancy, and also hand eczema, and this type of hand eczema where you get these small tiny blisters in the palms or the soles of the feet. We call them pomphilox. Can be quite very itchy, and unfortunately some of these things can get worse during pregnancy. Conditions that we know sometimes can improve in late pregnancy, like acne, it can improve, and even though eczema can get worse in pregnancy, in some people their eczema improves during pregnancy. And then there's this condition which is very also common in Afro-Caribbeans. It's a condition called HS, or hidradenitis suppurativa, where you get recurrent boils. So recurrent boils in the armpits, in the groin, underneath the breast. It's a very incredibly difficult condition to treat and very debilitating, and in the sense that, you know, it can cause a lot of scars and discharges and pain, and this condition can often improve during pregnancy. And obviously, psoriasis, I mentioned, may worsen, improve, or stay the same when you have that in pregnancy. So these are just some conditions in dermatology and their link in pregnancy. So I will briefly go through some common dermatological conditions in adults and children. Chickenpox, and this is how they look in black skin. So you can see the small, tiny blisters or vesicles that you can see. It's much smaller, so they're called vesicles rather than blisters. You can see on the skin in children. And the problem is, in black skin, it can leave you with a lot of scarring, and is the post-inflammatory causes or morbidities which we worry about, because it just doesn't clear away with the blisters going, but then it leaves you with all these incredible scars. And if you're very unlucky, these scars can take several years to clear. You know, people try stuff like bio oil and also many things to to try and help the scars to get better, vitamin E oils, all this kind of stuff. And they are all all things which people can try, but the underlying thing is a post-inflammatory reaction, and that's because in black skin there is kind of there are some cells we call fibroblast activities make scars thicker and harder in black skin, and therefore can leave you with this morbidity after the condition like chickenpox has even cleared. Eczema. This is a young child with eczema. Eczema in babies might usually start from the face, spread behind the ears or the back of the hands. And the problem with black skin is it can be very extensive because the skin dries much more, which is what eczema is a barrier problem. So there are myths about, is it an allergy? It's not always an allergy. Yes, allergies can make eczema worse, but it's not always an allergy. It's a barrier problem, and obviously it can be triggered by so many things, which could include allergies as well. But it's not always an allergy problem. If you have a very strong family history of eczema, asthma, or even hay fever, which we call these conditions atopic conditions, your child might be predisposed to getting eczema as well. And it's incredibly difficult because of the presentation in black skin. Is not just the scales or the redness. This is the itchiness and the thickening of the skin, which we call the lichen effect. It becomes more like a snake skin from how debilitating it can be. And the challenge for UK practitioners is, if as a child you want to treat the eczema, but you're worried about treating them with steroids. And there is this incredible fear or phobia of steroids in the community, not just among the general public, but also among doctors. And some doctors will be very, very cautious to treating eczema, and they will use the most weakest steroid as possible because of the fear of thinning of the skin. And as I've said to you earlier, in black skin, the skin is already thick. So therefore, if you're treating a black child with eczema, they need to use a little bit more potent steroid for a shorter period and be much more ambitious rather than giving them very weak steroids like hydrocortisone, and then it doesn't do anything. And then they keep on coming back and parents are not happy. So it's just the approach. The approach in black skin should not always be looked in the same way as every child. You have to treat the individual child rather than the condition as how we know to treat it. And that's the challenge that doctors face. This is again eczema, but you can see the presentation from the previous one. The previous one, this is kind of a scales, but this one is much more of a sandpaper appearance. And if a doctor is confident that this is eczema, they might think, what am I dealing with? Is this eczema as well? Yes, it is. It's the same condition. Is a presentation and appearance looks different. This feels much more what we call the follicular type of eczema, or the sandpaper feeling of eczema, rather than the scales that we normally used to. And that is the presentation of the pattern presentation in black skin. So this is another condition called keratosis pilaris, which is chicken skin, so people call it, and it's again is the follicle. You can see the hair follicles becomes very bubbly and rough, and it's a variant of eczema, so it can be very itchy as well. And so it should be managed in the same way, and that's again, you might need creams that are quite good for very dry skin, and sometimes steroids as well to help. We're lucky in medical profession that there are other creams called immune modulators or protopics, which have the added advantage of not thinning the skin, and also causing less depigmentation or loss of pigments in the skin. And so they are much more effective in treating skin conditions in black skin if we're worried about the side effects of hyperpigment or hypopigmentation. The problem with those conditions, those creams, is that they are not as strong or potent as steroids. But then still, again, they are better in terms of side effects. So even, what our approach is, use that potent steroid for a short period and then switch to a protopic, which will not be as give you more of the side effects of steroids. So it's just recognition from the health professionals what to use. Again, this is an eczema around the lips of a patient, and it's just the difference. This could be eczema related to an allergy, and eczema related to contact or use of a chemical or perfume or something, and so it is what we call perioral dermatitis or perioral eczema. But the appearance is much more of a sandpaper appearance or follicular appearance. Now, when you have a very itchy skin and you rub a lot, in black skin, it leaves the skin gets thicker, and that thickness is from excessive scratching, and so that's a very common secondary changes as a result of the skin type from eczema when you rub a lot. I put here some creams here which you can get or GPs prescribe. And there are various creams there. So it's important to understand that when you're treating eczema, there are emollients. So what we call emollients are here. They are various forms. Some of them are ointments. Ointments are oily base and less water base than creams. The advantage of ointments for black skin is it stays on longer, but it's not, people don't like ointments because it goes on their clothes, and then they don't like their clothes to get messy. If you prefer to use a cream, the idea is, well, fine, but you have to use it much more frequently than ointment. So the ointments are much more lardy, like Vaseline, whereas creams are white, alcohol-based, and much more lighter. And then you have gels, which are also a little bit lighter than creams. And obviously there are lotions, which are much more watery than creams. So these are all various vehicles in which emollients present. And I've got here some sort of steroids which are available. And the strength of the steroid is really important because on this picture is an Elocon ointment, which is a moderately potent steroid, which is very effective for treating thickened skin or black skin eczema. But it's too potent that most people will not like to use it on the face. And in fact, it might not be the first approach a GP will prescribe to you. They might prescribe to you some hydrocortisone because of a child and things like that. And you can come back, that's the issue. The issue is there's so many vast range of strength and potency of steroids, but their advice is to always hit it hard for a shorter period and then decrease the strength of the steroid and to use if you're really worried about a side effect. So the side effects of steroids are real. So this is a child who's got eczema that has been treated with steroids. And unfortunately, if you use it for too long, it will leave you this depigmentation or paleness of the skin, and which is what a lot of doctors are scared for, and therefore end up not prescribing good potent steroids. Another very common skin condition is ringworm. So ringworm presents a lot in Afro-Caribbean kids, and then it can give you just these rings on the scalp, which if you're treating, is very important to treat it properly, and also the doctors need to treat it properly and also treat the whole family if they've got siblings. The problem is if you give creams for black skin ringworm, particularly on the scalp, they are not very effective. So you need to, if you need to use a cream, they'll probably need to use a cream for 3 to 4 weeks. But we want to avoid this condition called carrion, which can lead to some pus production in the scalp. And therefore, the most effective treatment for ringworm in the scalp, particularly in black children, is tablets. And most of these tablets are not licensed. They are not licensed for children, but you can use it in an unlicensed drug in a way that is effective for a child. So you can use half the dose of an adult in a child. So but it depends on the experience and the confidence of the GP to recognize that this is a black child who's got ringworm, is not responding to a cream. I'm going to give him a tablet. Now, they're worried about kidney, liver tests and things like that. You can do a blood test. They can do a blood test and check the liver. But unless this child receives a tablet form of treatment, this will not go away. And if you treat the child, you also need to treat the siblings with either creams or shampoos to prevent spread in the family. This is another fungal infection also, which is very common in black skin, called pityriasis, where it can leave you a lot of paleness in the area of the skin, particularly in the summer. When you sweat a lot, you can see on your body, you have these scaly, very fine, scaly rashes there. And this is a form of fungal infection as well. The acne is a big problem. And the problem in black skin is not the acne itself, is the hyperpigmentation that acne causes. And as I said, you are treating an inflammatory skin conditions, but the scarring and the hyperpigmentation is giving a lot of cosmetic and psychological impact on the patient. And so it's important to understand how how the doctors will treat the acne. There are also acne related to certain conditions. So the acne might not be just a skin problem, but it might be a manifestation of a condition inside the body, hormonal problems, and as well, but also our own cultural practices. Some acne is kind of brought on by cosmetic use of oil-based pomade. When you plait the young girl's hair and you use oil to massage the scalp and you wash the hair, and the warm water drags the pomade on the forehead, they develop what is called pomade acne. When they use people use steroids to lighten the skin, or skin lightening product which contains steroids, you can develop steroid-induced acne. There are certain medications like steroids which can also induce acne, and so forth and so forth. There is very little evidence about kind of dietary involvement in causation of acne, but obviously the advice is a low glycemic diet, diets not so rich in sugars are kind of better, rather than using high glycemic diet in that. So when you get these pigmentation, post-inflammatory pigmentation, hyperpigmentation, it can take months and years to clear. And so it's important for the doctor to choose the right cream appropriately initially. And some of the most effective creams to prevent this pigmentation are retinoid creams. And it might not be the first line the doctor is used to. And azelaic acid also might not be the first line the doctor is used to. But these are very important to consider the skin type you're treating, because they tend to prevent hyperpigmentation much better than other forms of acne treatment. But also, I always tell my colleagues to have a very low threshold in referring Black patients with skin acne, which is scarring, to dermatology for oral retinoids, because that is the most effective way to prevent long-term scarring and hyperpigmentation. When you're treating hyperpigmentation, either as a result of acne or hyperpigmentation from conditions like melasma, that is common in pregnancy, it's really important to understand importance of sun protection. Sun protection is really key. Using a sun protection factor, it doesn't need to be a very high SPF factor. It can be a factor 15 or factor 30 because of your Black skin already. So you don't need to get a factor 50 plus, but it's really important to prevent the hyperpigmentation in that. And there are some creams that you can get prescription, things like retinoid, like adapalene, azelaic acid, and some of them are incredibly difficult to get on prescription because things like Pigmenum here, which is because they are unlicensed in the UK. These are some creams that you can buy over the counter to try for melasma or hyperpigmentation as a result of acne, and things like Effaclor, which there are these cosmetic products they sell. Eucerin also have these anti-pigment creams, which has incorporated in some sun protection factor to prevent darkening skin from melasma or hyperpigmentation from acne, and even from other skin conditions which leave dark pigments as well. The Pigmenone, as I said, is unlicensed in the UK, but these other ones are all over-the-counter creams, which you can buy them. Unfortunately, GPs cannot prescribe these for you, but you have to buy them from big drug pharmaceutical shops. Cultural practices that affect the skin. Lightening creams, it induces acne. I mean, if you go to Afro shops, you can see all the Kero products of skin lightening. And the problem is these conditions is these creams they contain steroids, they contain hydroquinone, and then they contain retinoids. Hydroquinone in itself is a very good in clearing pigments, but if you excessively use of hydroquinone can leave some staining on the skin. So if you see people who bleach, you can see they have these gray slate staining on the skin as a result of their excessive deposits of from hydroquinone use. Again, you can see it leaves you with acne and just an imbalance in the pigments as a result of these steroids in these products. So this is what we call the exogenous achronosis. This is caused by hydroquinone use for skin bleaching. And you can see this woman's cheek has had this gray stain there, and sometimes it's very difficult to get rid of this. And this is because of excessive use of skin bleaching product, which contains hydroquinone. In fact, in America, there were some studies about possible link with skin cancer with hydroquinone, and therefore it's banned. In the UK, you never get it on NHS prescription, but people buy things these days without prescriptions over the counter or on online. I was mentioning acne induced by pomade, so excessive greasing of the hair. Products using hair products can cause acne on the face as well. And then other hairstyles like braids, cane rows. There was a kind of a funny TikTok video going on about a young lady saying that whatever style of hair you do, they say your skin will break. If you braid it, it will break. If you do cane row, it will break. You get a fringes as well. So it's our practices. Our ladies do that. Whether you use extensions, the skin, the hair can be quite loosened, and then unfortunately you can lose these alopecia, this traction of the fringes of the hair, and then that can sometimes become permanent. And obviously, if you stop the braids and stuff, it will grow. If it becomes itchy, some steroid creams can help to prevent the scaliness and inflammation. But obviously, the lifestyle is what it is. And if the braids are too tight, it can break the skin, and it's sometimes difficult to recover. You can see our lady here who's got the fringes of the skin or of the hair is just receding because of very tight extensions or braids that she's had before. This again, distraction alopecia from extensions, from weaves, which can be a big problem in our community. For the men, we're not left at all. Also, close shaving can give us folliculitis or razor bumps as a result of our coiled hair. The hair is helical, grows back, and ingrowing hairs. Very difficult to manage. You can use conditions like using products like Hebe Scrub, Dermo, Octenisan. You can use that as a to protect the skin, or wash the skin to prevent the inflammation or infections which can build up from razor bumps and stuff like that, which can prevent it. Obviously, the advice is don't close shave, but if you don't want your hair, beard growing up, you need to do something, cutting them. That is really difficult, and that's really challenging. The problem is if it goes on, it can develop scarring, and you can get acne keloiditis like this, which is very difficult to manage from excessive shaving or rubbing and of the hair. And sometimes you end up giving steroid injections to flatten the keloids as a result of this. So it can be very debilitating for our men as well. And this is a very severe form. And if you get this, if you are developing this, please get your doctors to refer you to a specialist, because sometimes you might need oral retinoids to try. There are some laser treatment privately, and difficult to get treatment for these on NHS, but they'll always try tablets, which can help to reduce this first. And again, other form of scalp problems like folliculitis, they cover where you get the center part of the scalp becomes very thin and very itching. This is kind of a form of alopecia, and it's very, very common. And it's particularly almost exclusively among Black women, African-American Black women. And this is very difficult to treat, but there are good creams and steroids and tablets and steroid creams, as well as anti-inflammatory tablets that are used to treat by specialists in our clinics, and that they do respond well. But if you leave it too late, it can lead to scarring alopecia. And obviously, one of the very most worst bit of it is this central centrifugal secretarial alopecia, CCCA. We all know the story from the Oscars or something last time about Will Smith's wife, and this is kind of a condition that we know that causes alopecia, very common in Black women, and sometimes it's easier to shave it off because at the moment there's not much treatment available, but there are a lot of trials there. Some of the consultants, specialists in this will try steroid tablets or anti-inflammatory tablets, but there's no ideal treatment currently existing for CCCA. Antibiotics are tried, steroid injections are tried. Hydroquinone is used to treat lupus. It's been tried in this as well, but none of them has been very successful so far. And then keloids, as I said to you, because of the scarring potential of our skin, keloids are very easy to come up from traumas, ear piercing, and things like that. So either from guys piercing their ears or from having conditions like, this is shingles that has developed into a keloid scar in this patient. So you can buy some stuff over the counter like silicone sheets or dermatics creams, which are contain silicone gels that can be very helpful. Or your doctors can refer you to dermatologists and we can treat it with cryotherapy. So this is, I know this is quite a long talk, and dermatology is very extensive. I try to see how much I can fit in as much as possible. So I'm happy to take some questions. So I hope that was useful.
Thank you so much. That was extremely useful, Dr. Appiah, and what a massive, massive wealth of knowledge you've passed down to us in this in these 50 or so minutes. Thank you so much. We've learned a lot. I've learned a lot as well, even as a doctor, even as a GP. As you rightly said, we don't have enough dermatological training during our training. So this is excellent by all accounts. Thank you so much. Before we go on, I just want to crave everyone's indulgence. It's 11:55 at the moment, and there are a number of questions in the chat box. So I know that we probably will exceed the 12:15 close. I'm pleading in advance, if that's okay, maybe we might run a little bit late, but I think it's important that for such an important topic where we've had a lot of engagement, we're able to try and address everyone's concerns. So thank you so much, Dr. Appiah. As we've said, we've learned a lot. I'm not going to go into summarizing what you've said because I wouldn't be able to, and I'll leave the time for us to be able to address the question. So just a few themes I want you to mention before we start tackling the questions. Can people see you privately? Do you have a private clinic, and where can you be seen? So that question came up quite a lot. And what are the details of that, if you can tell us that?
Okay, so unfortunately, I don't do any private work. I only do NHS work. I'm a GP, and I work for only do NHS work. So.
Maybe you should consider doing private work. I'm sure you've probably been told so many times, but this is further confirmation for you because you have a lot of potential clients, people who would want to see you. So we will fire away with the questions and the comments that they're mainly in the chat box, and we will do our best to sort of go through as much as possible. So lots of thanks as well to you. Now, some of the questions we're getting are centering around, I'll try and read them because sometimes I accidentally skip people's questions, and that's not very good. So Jackie, our condolences to you. So Jackie has said that her father died of skin cancer, and for a number of years he'd shown it to the GP. It was an area on the heel of the foot where he had pain, and it wasn't referred, and it later turned out that as soon as the dermatologist saw it, they instantly diagnosed skin cancer, and I guess unfortunately the dad passed away. So a very traumatic story there, and very unfortunate. So absolutely, you're right, we do need a lot of training, and that's why sessions like these are really useful. And thank you, Dr. Appiah, for that. Dr. Appiah, there's a question about about GPs prescribing lotions and things like that. So someone is asking, is retinol okay for black skin? Because someone thinks this could make the skin more sensitive. So
yes, retinoids are very good in treating acne. So the type of retinoid creams that GPs can prescribe is one known as adapalene. When you start using retinoid as we initially start to prescribe them, they can itch and they can be quite sensitive or irritating. So our advice is always don't use it daily as prescribed. You can start them once or twice a week or 2 or 3 times a week until your skin gets used to them, and then you can increase the frequency once you kind of become more, your skin can tolerate them. But yes, we know that burning and stinging can be one of the side effects of retinoids, but they are quite good in preventing hyperpigmentation, particularly in treating acne and stuff like that. Yeah.
Okay, thank you. Thanks. And there's also another question about the bumps on the scalp. I suspect that's the pseudofolliculitis barbae one. And that's obviously very important to the men. We see a lot of our men with these bumps at the back of their head. What can they do to help themselves? Obviously, there are things that may need to be prescribed, but what can they do to?
So the key is a prevention. And the issue is because the black skin has a tendency to develop keloids quicker. It's trying to prevent them in the first place. So when you start squeezing them, when you have the first initial one, that squeezing is going to cause inflammatory response, and that's your cells tends to gather much more cells which make you to develop keloids. So prevention is really better than cure, which is difficult to cure. Shaving with antiseptic solutions some of the things that I said, some Hebrew scrub, octanosan, dermal creams that you can buy over the counter. They are all antiseptic. We've got chlorhexidine in them, which are quite good to just kill the skin bacteria. Because some of them, the inflammation is not just the shaving. It can also be induced by our skin have a lot of bacteria, sweat, everything on there. So if you kind of treat that, prevent the infective area there or colonization on the skin, that prevents the bumps from falling in the first place. So if you can decrease the shaving practices, which is very difficult, first thing, but if you're going to shave, use some antiseptic solutions to do that. If you start getting inflammation, it might be some convincing to could get your GP to prescribe you something like Fucibet, which is a steroid cream with a bit of antibiotic in it, and that can be used initially when the area is a little bit red and inflamed. But if you make it develop into the thickened scars and keloids, that is incredibly difficult, and you need referral to think of oral retinoids as initially, and sometimes we do steroid injections for the very thick keloids.
Right. So catching it early and preventing it
Absolutely.
from getting worse. Okay. And obviously avoiding the close shaving, which is quite difficult, isn't it?
I know it is, yeah.
Yes, right. Okay. So another submission. In the last few years, the skin on my face has turned very dark. The pigmentation, it seems, is very dark around the eyes, forehead, and the cheeks. I am 60. What is this, and what can I do? I've also got a lot of skin tags. So obviously this is someone's sort of scenario here.
So I think that the key is that hyperpigmentation needs to be think of. Is it purely from genetics, or is it something medical going on inside? So there are causes of dark pigments which can be related to conditions like diabetes. Sometimes there can be conditions are internal organs or cancers and things like that that can lead to excessive hormone production. So it's important to make sure that there is no underlying cause there if you're getting dark pigments. I did mention things like melasma, which can be a state in pregnancy, but as you get older, people can get melasma from just without necessarily being pregnant. It can happen. So underlying cause should be eliminated first, and then the most important thing is to avoid sunburning. So that's where I say that black skin and the use of sun protection is really important, because we go out and think I'm black, I don't use the sun protection. The more you get burned, the darker your skin becomes, and then it becomes a vicious cycle. So that's why you also need sun protection when you're going out as well. So I think knowing the underlying cause and prevention is also key. And there are some of the creams that I mentioned are quite useful to try. The Eucerin, the Effaclos and Thiamidos that you can buy over the counter for hyperpigmentation, that can be useful.
Okay. So would you recommend that this lady sees someone as well to
particularly if it's quite unusual?
ruled out?
Yeah.
Okay, thank you. I sort of hide myself under the table when you talk about the sun cream bit, because sometimes when I'm charging out of the door with my little ones and I get to nursery and they're like, oh, did you bring the sun cream? I'm thinking in my head, oh, she's got natural sun cream, but maybe we should really take these things very seriously. So we still need the protection, even though we've got the dark skin. That's a very important point. Right. So someone wanted the details about Pomfolics, but I've put that in the chat box. Again, can we make appointments to see Dr. Appiah? So unless you're in his catchment area and he's your GP, I guess not, but hopefully he's going to start a private clinic soon after this. Right. The other question is, I get pimples wherever my hair starts growing, and it has left black spots on my face. What could be behind this, and how could I treat it? Is there any cream or medicine that I can get over the counter, please?
So, so the spots, yeah, it's that pimples are inflammatory skin cells. So more likely you're getting much more folliculitis from where your hair is growing. And the key is some of the anti-inflammatory creams that I mentioned, some of the anti-hyperpigmentation creams that I mentioned are quite useful. It's worthwhile to get your doctor to have a look at it, because if it is folliculitis, then it needs to be treated properly. If it is acne, because what a layperson calls a pimple might not be what the doctor will see as a pimple. So it might be just folliculitis. Therefore, you need to treat it properly with a cream for the folliculitis. If it's acne, then all the treatment for acne are quite useful. Even if you use some things like Effaclor, which are used for acne, but they are not prescribed, can be bought over the counter. They are quite good for pigmented skin. But if you see your doctor, they can prescribe things like azelaic acid for that as well. And if there is an indication for antibiotic creams as well, that might be quite helpful for that. But yeah, it's really difficult to pinpoint what you're describing unless somebody sees you to make the diagnosis correct, whether it is purely folliculitis or acne.
Thank you. Thank you. So at least you've got some ideas there, and you could probably go along and see your GP. And if they're not clear, you could probably ask, could it be this? Could it be that? Sometimes that draws people's attention to what they should be thinking about. And the other question following that relates to the melasma medication you can buy over the counter. So I guess you mentioned the azelaic acid and a few other things, but we can't get azelaic over the counter. So what can they get over the counter?
No, you can't get azelaic over the counter. You can get Eucerin anti-pigment cream. So it's called Eucerin. The anti-pigment product in it is called thiamidol, which is quite good in preventing pigmentation. Also, La Roche-Posay has the Effaclor, which is also has got some anti-pigment properties in it as well. So they are quite expensive, those, but I guess unlike going to get things like Pigmenom, which it's on license in the UK, well, that depends where you work in the UK, which are very in the hundreds. These are reasonable, 30s, 40 pounds.
Okay. So I hope that helps, Elsa. Now, another question is, if your family is predisposed to asthma, what can be done to counteract this in future generations? Okay, so I suspect the person is talking about eczema. I suspect this question is relating to eczema, not asthma, although, I mean, if it's a topic, obviously. But so if your family is predisposed to eczema, what can be done to counteract this in future generations? Is there anything that can be done, please, Dr. Appiah?
I think it's about the awareness. I don't think you can change your genetics if you can, but it's just about awareness to when you see a skin condition, if you have the family predisposition to eczema, asthma, or hay fever. And then when you recognize that, then you need to draw attention to your doctors, what you think it could be linked to, because sometimes they don't have that information, and then they don't recognize your skin condition as eczema because it might not present in what they are used to as eczema. So it's either drawing them the attention to your family predisposition and then the skin condition and whether it could be eczema.
Yeah, okay. And what is the link? Can you throw a little bit more light on, because we know that for some people who are asthmatics, they also have a high predisposition of suffering from allergies, but they also suffer with eczema. So you mentioned the word atopy. Can you tell us a little bit more about how these things could be relevant or linked?
Yeah, so atopy is just the predisposition to allergies, and really either the allergens being from hay fever pollen, therefore giving you hay fever, or asthma, which could be triggered by exercise or dust or house dust mites and things like that. Whereas in eczema is a barrier problem. So that we think that I always describe the picture of a brick wall of eczema. So it's like a brick wall, and the barrier is the mortar between the brick wall. And so the defect in eczema is a barrier problem. So the mortar is opened up, and therefore the brick wall is not as tight as it's meant to be. So whatever is predisposing the brick wall to be loose causes the skin to become inflamed, and that makes it itchy because you producing inflammatory scales, you get scales, you get the presentation and the itchiness. And so that's why the treatment involves an emollients, which is really doesn't dry. We call it moisturizer. They don't moisturize the skin. They basically act as a barrier. So it's like the brick wall is loose, therefore you're putting a bit of plastering on the skin to prevent it from drying out. And then you want to use, once you prevent it from drying out, you want to use something to seal the inflammation between the bricks. And that is what the steroids are. So you use the barriers, the creams as the barriers, and then the steroids as the anti-inflammatories to seal it properly. And so it's just the defect in kind of the barrier mechanism. And that's why you get the defect the same, the response to allergens in hay fever, and the response to the allergens in your lungs in asthma. And also some people, when they get stung by a bee and you get urticaria and hives and things like that, those are all atopic conditions as well. So they are linked, and that's how they are. Yeah.
Thank you. Okay. Now we got one of our YouTube viewers asking a question about why does eczema happen to black skin? So that's the question. Why does eczema happen to black skin? I guess that's probably most of your talk, but I guess if this person's idea is that it's predominantly happening to black skin, is there any thinking behind that, or is this a valid?
So I did mention in the beginning of the talk that because of the architecture of the black skin, it dries out much more. That because of the tendency for black skin to dry much more, and eczema is you're losing the ability for your skin to hold moisture. So therefore, by default, your genetics of your skin makeup is always making you dry much more quicker. In fact, the research shows that eczema is worse in Asian skin than black skin. And even though if you look at the spectrum, Asian skin are slightly lighter, but they tend to have much worse form of eczema. But the dry skin in black skin is much more of the difference in presentation in as well. So it's I don't think it happens. The why is the same why it happens to anybody anyway. But again, it's a presentation much worse in as well.
Yes. So it's not just limited to dark skin, is what we're saying.
Yeah.
Eczema can happen to any skin type. but the presentations would vary. Thank you for clarifying that. So we're still on this theme of the atopies, the asthma, the hay fever, the food allergies, and someone's also asking a very important question, that how can we best manage a child's eczema if that child's, eczema is coupled with asthma, hay fever, food allergies, which then cause the eczema to flare up, which is a common presentation we see in general practice. So how do we manage this then?
I think you have to look at it. If there is a high suspicion that your child's eczema is related to a food allergy, you need to see an allergy specialist. And that's a really important thing. Unfortunately, I don't know from where you work in, Dr. Santi, but in my patch, to get a referral to allergy clinic is difficult. Your child has to present with anaphylaxis reaction before they will accept any allergy testing. But the presentation, particularly in babies, will be very obvious, and it might start with a cow milk protein allergy, and then you start with the vomiting symptoms, and then your skin changes as well. Because as we know, the allergy type in the skin is not a type 1 reaction, which you get with anaphylaxis, is a delayed type reaction, which we call a type 4 reaction. So allergy specialists are much more interested in the type 1 reaction, where they'll do the skin prick test and they say you're allergic to eggs, you're allergic to this, you're allergic to that as well. And most of the time it's a matter of elimination. So even type 4 reaction, they'll tell you cut out dairy products, cut out this. And then you need to do it for a considerable number of times to see the difference. You need to do at least 6 weeks of stopping something to see if it works. So it's a matter of a lot of trial and error, because these conditions are common. And then if we have a system, a finite system that we have, it can all be addressed in the same way. So it's really difficult. You have to look at the whole condition and which one do you address, because their presentation might predominantly be the asthma and less of the eczema. And some of them, their presentation might be much more of the eczema rather than the asthma, or vice versa.
Yes, that's really true. It's so hard getting referred to an allergy specialist. But as Doc has said, we can keep food diaries, we can look at patterns and see what could be a possible cause, eliminate things, and allow time as well when we do these eliminations to see if it makes a difference. But that's a really valid point, that these things can co-present and they are difficult to manage sometimes. Yeah. So more questions, and as we're going along as well, lots of thanks in the chat box, lots of acknowledgements of the good work that you're doing. Now, just on the thread of sort of diet and all of that, we do have our Healthy Heart sessions on Tuesday evenings, where we have dietitians, nutritionists, and lifestyle specialists come and talk to us. So please do tune into those sessions as well. We also like to receive feedback on the talks that we bring you and these sessions. So please do complete the feedback polls that are being put out, so that we can gather this feedback and work on improving what we bring you. Or you can write also, or send an email to health@cahn.org.uk, suggest the topics you want to have, and let us know if you got any concerns about previous topics that have been discussed. Right, so Dr. Kwasi Appiah, my 9-month-old baby has had a rash on his stomach and the back since 3 months. I was told it was due to bronchiolitis, and that he suffered at 3 months. Issue is the ones on his stomach are now raised and spreading to his private parts. What do I do? Creams are not helpful. So that's that question. And then I'll bunch a few for the next bit for you. We do have quite a lot of questions, so we'll endeavor to keep them, the answers as brief.
I think it's important. The most rashes are challenging for people, for doctors to diagnose, and it's important to get the diagnosis right. So if if they have a rash, what is the cause of the rash? Is it, and that's the first thing. Without getting the diagnosis right, then the management becomes challenging. So if it's not diagnosed as eczema, then what is it? Is it a fungal infection? Is it, so I think really when rashes is just a presentation. So you really need to ask the doctors, what is the diagnosis of the rash? And they could, if they are honest to say they don't know, that's a different answer. But you really need to diagnose the rash, and then the approach of the management is based on what you think the diagnosis is. Because as doctors, we have a lot of rashes present in various parts of the body, under the groin and the armpit, and then sometimes they are inflammatory rashes, which is eczema, psoriasis, or it can be infective rashes like ringworm or tinea or erythema, which is a bacterial infection. And so the same rash in the same spot has different diagnoses, and sometimes brave doctor will say, I'll try a triple action treatment which will cover all bases, and that's sometimes the approach, but it's actually making the right diagnosis and of what you think it is, and then making. Sometimes you might take skin sample test, you do a skin scraping to check for bacteria, to check for fungal and things like that. And so that the most important is making the right diagnosis and then applying the right management for it.
Okay. Yes. Okay. So please, as he said, probably go back and see your GP, because if they initially thought it was a viral rash because they said it was due to your bronchiolitis, and this is 3 months down the line, you probably need to go back so that they would reevaluate this rash. As he said, it could be anything. A number of rashes can present that way. Now, a few questions I'll probably bunch together. They're relating to creams, emollients, steroids. So the sort of theme around these questions are, which creams are there any natural products that can be used, for instance, and are there any ones without steroids? And also someone has said, I use double base gel for natural skin. I think it's good. I guess that's sort of reacting to the earlier comment, but also someone asking, are there natural products that can be used to treat skin conditions? Thank you.
So I think, we like the word natural because of the packaging. The only natural product you might probably say is if you get a pure oil from, shea butter or whatever is natural, but once it gets into a container, it's preserved. There are things in it which takes the natural into inverted commas. And so I think it's just, we need to be realistic. Once something is packaged, there's been something inside to preserve it. And so it takes the natural away from it. That's the honest truth. But if you look at, if you go to, I always tell my patients that the best cream is a cream that works for you. And the reason is that for somebody, a lot of children or a patient with eczema, they will have gone through a lot of creams because they don't get on with it. And they will swear by one that it did the job. And then they meet another child and they will swear by, this didn't work for me. So there is nothing like the best cream. The best cream is the one who works for you and the one that you will use, because you can prescribe a cream for somebody and they will use it once a day, and it's not effective, because if you want to use a cream, within an hour or two, it's dried your skin. Therefore, you need to use it much more frequently. If you prescribe an ointment, which is just a vehicle in which the emollient is packaged, is much thicker, a lot of people don't like it because it's too greasy, and therefore they don't like it, so they will not use it. So you have to choose what works for you. You might prefer a lotion, which is very watery and it feels like you don't do anything, but some people will like that. It all depends on what works for you. But there is, and that's why there are tons on the shelf, because they know that somebody will like one other than the other.
Yes. And it is true that in practice, emollients, for instance, are a typical one, isn't it? Someone will find Diprobase useful. Someone says it flares my skin up. Someone says Dermal is my preference. Someone says Cetraben. So really, it's what works for you. And if one doesn't work, sorry, carry on.
And there was a bit of your question about which of them don't contain steroids. So emollients, in a sense, are not meant to be containing steroids. So they are just for moisturizing and act as a barriers. If a cream contains steroids, then it is a steroid for anti-inflammatory purposes. So it should not contain steroids to use on your skin regularly. That should always have a time limit usage if it's steroid, because you're treating it for a period and then you carry on with your emollient without the steroids.
Thank you. Right. So Dr. Appiah, so I'll give you about 3 or 4 questions together. Hopefully you can retain them. How can we avoid hyperpigmentation where the center of the face is lighter than the outer part? So hyperpigmentation in the middle of the face, how can we prevent that? What would you recommend for scalp, avoiding the creams you said are not helpful to you? So what would you recommend for the scalp, so that people don't have trouble with the scalp or end up with the pomade acne? So those 2, the hyperpigmentation and the scalp. And then finally, I know baldness is natural, but from experience, can you advise creams that can help to recover baldness? So those 3 for you. Can you remember them? Yeah.
So I'll answer the last one first.
Okay.
If you see me in the picture. Look, there's no creams to avoid baldness. It's natural. That's my answer to the last one. If you're talking about hyperpigmentation with the paleness in the middle, so I think that I can see the person is describing the pigmentation around the cheeks and the forehead. That in fact the diagnosis is really important, whether it is melasma. Because if it's melasma, then the diagnosis has to be made rightly, and then the hyperpigmentation can be treated with all the things I've mentioned about you managing melasma. Sun protection is a key, because sun protection makes hyperpigmentation worse, and also then all the anti-pigment medications, or which we call tyrosinase inhibitors, like the thiamidol from Eucerin, or the niacinamide from you get from the La Roche-Posay Effaclar, or you can get the ones that can be prescribed by the GP, like azelaic acid for the hyperpigmentation. So those are treatments. So they're important to treat. You don't treat the presentation, but you treat the diagnosis. Is it just post-inflammatory hyperpigmentation, which will always be after a condition, or it is a primary hyperpigmentation condition like melasma or something of that sort, or is it induced by a condition from within, medication, and all sorts of stuff? So diagnosis is always important, not just how it's presented. And then you go to the management based on what you think the diagnosis is. Then what was the other question about creams? Avoid. I'm thinking maybe the person is asking about pomade acne when you use greasy. I mean, it's our hairstyle, our hair practice in our culture. The scalp gets dry, you plait the hair, you need to put the pomade in there. I think that the key is recognizing that when warm pomade is melting with warm water, or sweat or whatever, and it seeps onto the forehead, you can develop pomade acne. Whatever strategy you feel might be used in moisturizing your scalp is entirely up to you, because you can use whatever vehicle, whether you use olive oil, coconut oil, all these oils can block the pores. And if you use light emollients with creams which are lighter, they don't moisturize the skin well enough. So you have to use much more frequently. So it's a balanced game. You need to look at what works for you and your hairstyle practice, and how you can use to maintain it. And sometimes you can't avoid it. Yeah.
Okay, thank you. So Isilda, I think you've typed a question. I'm sorry, I can't understand it properly. I think you're referring to azelaic acid, but if you can kindly rephrase the question, the full question, and then I can put that forward to our doctor. So I'll move on to the next few. When giving a child steroids for a skin condition, is there a time scale that you would advise, for instance, no longer than 4 weeks before it sort of starts to thin the skin? So time frame for steroid use, basically. A black patch has suddenly appeared on my forehead, has been there for 2 months. I've been given a cream, but it's not going away. What can this be? So I guess this is one of the ones where you probably do need to see your GP to be diagnosed. But if Dr. Kwasi wants to add on, I'll let him do that. And then also, Dr. Kwasi Appiah, can you tell us of any dermatologists who deal with black skin if you don't do private practice, Kwasi? Yeah. You're in trouble here. You've got to do this private practice. Otherwise, show us where to go.
Okay, so I think the first one about the steroids. So steroids have various strengths, and it starts from hydrocortisone are the weakest forms of steroids. Dermovate is the most strongest form of steroids. So whenever a doctor is prescribing steroids, the first thing is they need to know the diagnosis of the condition you're treating. Secondly, the location of where they want the patient to apply the steroids. So you have to put a different steroid on the face and a different steroid in the part of the body, on the neck and palms and soles of the feet, because the skin on various parts of your body have different thickness. So most of the time, our caution is on the face, we avoid very potent steroids, and that is rightly so. So hydrocortisone will probably be the first choice of steroids by most doctors if you have eczema on the face. Duration might be 5 days, 7 days maximum. Okay. However, if you know the condition in a black person, the hydrocortisone might not be strong enough. If the steroid is not controlling the eczema, you might be confident, the doctor might be confident to use a moderately potent steroid like Eumovate, but for a shorter duration, for like maybe 5 days rather than a week. So it's all about the experience and the practice of the doctor, where you're applying the steroids and the duration. And that's the key, because when we talk about steroid thinning the skin, you have to use the steroids every single day for at least 3-4 months before your skin will thin. So the cautiousness is sometimes is put on ourselves by the medical profession. And if you look at the side effects of the leaflet of the steroid creams, because the manufacturers are very cautious, hence it limits how long, doctors want to risk the management for the patient. What we tend to do sometimes is use it, review, or maybe use a second line like a non-steroid cream like a Protopic or Elidor, which is pericolemus, which they don't thin the skin and are much more forgiving for longer term use. So doctors might use those creams as opposed to steroids for sensitive areas of the skin, which might require a longer period of use. Certainly in the palms of the hands and the soles of the feet, where the skin is much thicker, if you treat anybody with hydrocortisone, it will not work. You need a very strong steroid, like a potent steroid, for thicker skin areas. That's the key. It's about understanding where you're treating the condition.
Okay. All right. Any very brief 2-second comment on this, on the spot on the forehead at all, or?
I think that without a diagnosis, it would be very difficult to say what it is, and certainly for skin health, black skin dermatologists that I know were very good. I mentioned her name, Dr. Sharon Belmo. She is a consultant dermatologist. I think she's in Croydon or so, and she wrote the chapter on skin of color in the British Association of Dermatology curriculum. And she's got an author of research at Nottingham University on skin of color. So for any clinicians there that want to do things on dermatology research on skin of color, black health, Nottingham University have a website for skin of color, and Sharon Belmore is her name, and I think she does private. She'll pay me for this, but yeah, she's
free signposting, right? Yes. Okay, so sorry, I don't intend to put pressure on you, but I think we probably will need to speed up a bit for the next few. So I have a burning question. Someone says, is there a cure for nodular prurigo? If one has tried all the steroids, all the immunosuppressants, had chemo, PUVA treatment, emollients, biologics, everything, you name it, she's had it. Is there anything else, and what causes it? So very briefly, because it's already 12:34. And then the next question is, I get hay fever, which was described as seasonal rhinitis. Sometimes my inhaler helps when the pollen count is high. My GP has not diagnosed it as asthma, and I'm now on an asthma action plan. Is this asthma? Correct the diagnosis for me. Okay, well, and yeah, so those two, please, quickly if you can.
So the short answer is there's no cure for nodular prurigo. It's an incredible, difficult condition to treat. And so far, the biologics and everything, we don't have any cure for nodular prurigo. That's a simple answer for that. Yeah.
Right.
And the hay fever, I think, you know, as a GP, you know, most GPs can treat hay fever-induced asthma as asthma. And so if you're getting the symptoms of hay fever and wheezing, it might be just seasonal asthma, and you know, you can treat it as asthma for that season with inhalers and everything is fine, and that's probably fine. If you want a diagnosis, that's the diagnosis, is hay fever-induced asthma or seasonal asthma, whatever you want to call it. Some people have exercise-induced asthma, but it is asthma.
Okay. Okay. So someone has been prone to acne since her teens. Why do you think this happened? It got so bad, she ended up on Roaccutane, but it has come back again. And she's now in her later life. And what is the best treatment for chicken skin on the scalp? So keratosis pilaris.
Yeah.
And yeah, please. Thank you.
So there is I mean, it's difficult. I mean, if you have prone to acne most of your life, we know that when we even treat patients with Roaccutane, we don't guarantee that it won't come back again. It's difficult. I don't think there is an answer to that. It's a lot of skin conditions can go into remission, and then obviously the triggers of stress and other things can bring it back. But it's never cured. We feel that hormone-induced acne gets better, but it doesn't do that for everybody. So we still have patients we're treating with Roaccutane in their 40s. So yeah, it's difficult. It's just some people are just different. You can't have an answer. Chicken skin, keratosis pilaris. I think one of the advice is if you're using moisturizers for keratosis pilaris, something containing urea. Flexitol is the brand name, but it's got urea either. I think there are other products which has got urea, so it's got either 25% urea or 10% urea. For this face and scalp, maybe a lighter strength of 10% urea in Flexitol is fine. And then I think Eucerin also has a urea based one. And then for the thicker part of the body, you can use stronger strength of urea, which is 25% urea. In fact, they might sell it at heel balm because they are for thickened skin on the heel, and it seems to work well with keratosis pilaris, though it might take a long time.
So thank you so much. Apologies, we've had so many questions. I don't think we've been able to go through every single one of them, but I think that the broad themes around most of the questions have been tackled and dealt with, and Dr. Appiah has given us a wealth of knowledge. So the last thing I will put to you is just wrapping up all that's left, and then you could probably just give us a bit of insight on those. And then please, if people have any questions that haven't been answered today or any comments, kindly send them to health@can.org.uk so that we can directly tackle your question or answer them. I really must apologize. It's been a very lovely session, and we have had really a lot of questions, so we've not been able to go through every single one of them. So just briefly, treatment for dry, scaly skin. Someone is talking about psoriasis. How can that be managed? Again, dry skin on the face. So generally dry skin issues here. I'm just trying to see if I can get all the right. Just give me a few seconds to scroll through and put them together. See if there's anything that we've missed. I'm sure we probably might have skipped a couple just because of the sheer numbers, but essentially someone also has her child under the peds involved in a LEAP study because of allergic things going on as well. But yes, if you could kindly tell us about the psoriasis, please, how to manage it, and then the dry skin on the scalp and on the face. And what we'll do is, please, can the team collate those questions which haven't been answered, and the names, and we can get those sort of answered and sent back to the people who asked the questions. Thank you.
So psoriasis is managed as psoriasis in anybody. I think the most important thing is making the diagnosis. That's the bottom line. If you have a dry skin, dry scalp, and the diagnosis is made correctly, then appropriate treatment approach is given. So, for example, dry scalp, is it psoriasis or is it seborrheic dermatitis? And so I think making a clinical diagnosis either from your GP or dermatologist initiates the approach in the management, because the approach will be what you moisturize with and what you treat the inflammation. So it's all inflammatory skin conditions. So the diagnosis, the management, what you treat in an active inflammatory condition with, and then maintenance. And that's the key. So with psoriasis, it might be moisturizer, and then using something with a bit of steroid in it, particularly on the scalp. Things like Betacap or betamethasone scalp applicator. Sometimes you need something with the gels, which are applicable much more better on the scalp, in a sense. And really managing it with, kind of moisturizers or shampoos, which help to remove scales. The content of the products is really targeted to what you are treating. If you have a lot of thick scales, you need something which are used for descaling, so a salicylic acid containing product. So not all, you can't apply the same to everybody, because if somebody hasn't got thick scales, then you don't need a salicylic acid product. If they just need a Capasol, they need just cocoa shampoo or some coconut oil. It all depends. So I will say that making the diagnosis is the first key to allow whoever is treating you to give you the right thing. Yeah. So advice without making the right diagnosis is really difficult. Yeah.
And I think probably we might have to have another session to bring you back to address some of these issues that are left over, because I feel as though I'm rushing through the end of the questions, and I don't want anyone to feel dismissed in any way or to feel as though we've not answered their questions. So we will give a really massive thank you to Dr. Kwasi Appiah for a very useful session. We've all learned a lot. I've learned a lot as well, even as a GP. And for those who've raised your hands up, who we haven't been able to call, or who've posted questions who we haven't been able to address, please post your email addresses in the chat box if you want the answers to all the questions collated sending to you. So what we'll do is we'll collate the questions, we'll put them together on a spreadsheet. And if you do want those, please can you post your email addresses right now in the chat box so that we can send that information out to you. Dr. Appiah, look, thank you so much. It's It's been so great to have you. And thank you to all our viewers. You've been really patient. We've had over 100 people on Zoom, and we've got people on YouTube and people on Facebook. I know some people have had to leave because of time, but we have learned a lot and we're really grateful. Thanks for your time. And please, I think the take home for you is you should consider opening this private clinic.
Okay.
Thank you. So over to Danielle to do the closing for us. And once again, thanks for your time today.
Thank you.
Thank you.
All right. Thanks a lot, Dr. Diana. A massive thanks to Dr. Kwasi Appiah for this informative session on recognizing Black skin condition. Doctor, we appreciate you for your wealth of knowledge that you've shared with us today. A massive thanks to our wonderful chair, Dr. Diana, for hosting our Health Hour session every Saturday in such a brilliant manner. Dr. Diana, you know we love you. A big thank you to all our CATHIP partners and to all our attendees on Zoom, Facebook, and YouTube. You can access Dr. Kwasi Appiah's slides for today's session by emailing health@cahn.org.uk. So we have some exciting upcoming events to share with you. The first slide. Join us this Tuesday, 21st June, for an informative cooking masterclass from 6 p.m. to 7:30 p.m. The guest speaker is Sylvia Ofobe, who is a registered nutritionist. For further information, please email event@cahn.org.uk. Next slide, please. We are back again next Saturday for our CATHIP Health Hour with the same link and the same time. The topic is lupus and fibromyalgia, and this will be led by Dr. Kenny. Next slide, please. Windrush Day, Windrush Day, Windrush Day. Our next Windrush Day is taking place next Saturday, which is on the 25th of June from 12 p.m. to 6 p.m. at the Alexandra Park, Manchester. This event is going to be packed. It's going to be packed with exciting activities for everyone. Please be part of it. Come along with your loved ones, friends, families, and let's have great fun and as well learn. Please visit our website for further information. Our next slide. Right. Visit our website for our counseling service and also for our family and advocacy support services. For further information, please email help@cahn.org.uk or call 07710 022 382. Thanks everyone, and have a lovely, lovely, lovely weekend. Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.